Well, Sister Funnell, thank you very much for helping us out here. Surgical instruments for newcomers to theatre are a complete mystery, so do you think you could take us through some of the commonly used instruments?
Absolutely. This is a basic major general set, commonly used ranging from a hernia repair up to a very complex major bowel such as an anterior bowel resection or an AP resection, and all upper GI work as well. We'll start with the obvious. We're going to prep our patient. A very good instrument I'm showing you here is a Ramsay sponge holder. Many uses for the Ramsay sponge holder. Make a little mop like this to mop the skin and discard. And then you prepare your sponges using the very same instrument, as you can see, as I prepared there. Acts as a blunt dissector, mops up blood, and is a good thing just as a retractor as well. So it's got, you know, it's got many uses. But be aware that when it's loaded, particularly if you've got someone junior and not too sure, or a doctor wants to load a swab, you must ensure that when you load your swab, that you don't advance the Ramsay sponge holder too much, too far forward, that when it goes inside the abdomen, the metal is showing and it can traumatise the tissue, or that the nurse hasn't, or the doctor hasn't prepared it correctly, and it's all floppy, and therefore it won't help in your blunt dissection as I'm demonstrating here. Great for open gallbladder surgery. Many of our surgeons in this hospital will use it to grasp the gallbladder and then obviously create a bit counter pressure so you can work around the Callet's triangle. Next we've got a range of scissors, and we have here 3 scissors, curved Mayo, straight Mayo, and then Makindo. Absolutely, let's think about getting into our patient who's said a major laparotomy or a hernia. Depending on your surgeon, we have one surgeon here that loves to use the curved Mayo when he does hernia repairs, but the majority of our surgeons will use a much finer dissecting scissor to do the hernias and the major abdomens, and actually getting inside, particularly there's a lot of adhesions because it's perhaps a safer method.
So in general, scissors, you might call them dissecting scissors or suture cutting scissors?
Absolutely. So these, as you can see, and I'm sure all of you have been taught when you handle an instrument how you hold them, and that you wouldn't go in with them open to cause any harm, and that's perhaps another phase of the training. But ideal for cutting sutures. Quickly just going back to our curved Mayo, ideal when you're going to that major abdomen, when you've done your midline, once you've used your blade, this is the instrument that will get you into the abdominal cavity, nice and strong. And perhaps anyone that's had a redo hernia where you've got a bit of it's all a bit fibrosed,
yeah.
A good pair of scissors, because it will blunt the Makindo.
Sure.
Forceps, again, a range of forceps. We have 6 on our sets here, and we have, I'm going to demonstrate for you, a Gillies, toothed, and a Makindo non-toothed. Again, very, very commonly used instruments in every theatre and in all disciplines. Ideal for sewing up, doing that subcut.
Subcuticular stitching at the end.
Absolutely, perfect for that. Mainly on the smaller incisions, because if you were sewing up a major midline incision, you'd want something a bit more robust, and that would be a Lane's toothed, and again something similar in other hospitals. So there are 2 forceps, but again ideal for something like a hernia repair. Even actually, we say about major abdomens, it's not uncommon now for surgeons to use a handheld diathermy, particularly the younger surgeons coming along. And if there's a bleeding point where you're using the spade, they will pick up the bleeding point with the toothed Gillies, and then the assistant will touch with the diathermy spade, and they're used for that also.
Okay.
Again, the Makindo forceps, fabulous. Non-tooth forceps, used again for a lot of soft tissue around hernia orifice, lumpectomy type work. Again, you can use bleeding points for those as well.
And the big difference between the 2 really is that some are toothed, some aren't toothed, and the tooth are traumatic, and you wouldn't want to do
very,
those
very
inside the
important, particularly when you're going, for example, you're going into an abdominal cavity, that you do not hand the surgeon a toothed pair of forceps, because they could grasp the bowel with that and cause trauma, and maybe a hole in the bowel. Not good at all. Then we move on to our non-tooth forceps, and they range in, we'll go on to another table in a second when we go deeper from this set. These are called Stillies, and they're ideal when you're helping to pick up bits of tissue, maybe to assist your surgeon when he wants to dissect further into the abdomen.
And we're moving on to clips next.
The clips, yeah. On this set here, we have dunghill forceps. There's 12 in total here. Ideal for taking little vessels or bigger vessels. There is a finer instrument that's similar to that, and it's called Mosquito, and I'm sure many of you may have come across them, but basically it's much finer. But again, used for a range for superficial surgery like hernia orifice, and again used inside a major abdomen. On the upper side, the deeper you go, obviously they're going to be too short. However, they're often very good to perhaps to take the tail of a swab that's staying inside an abdomen to remind you that the swab is inside. Perhaps if you're doing a purse string on an anterior bowel resection, you might want to clip your proline with that. Then we're moving on to chunkier. So you're just going up in a range of length, if you can see there. And I'll show you. This is a Spencer Wells forceps. And again, that's just going to be used probably when you're doing something like a hernia orifice, perhaps a bit too chunky, but again, depending on your surgeon. Most of the surgeons in this hospital would use the Dunhill that I demonstrated earlier, or they would move on to Burkitt, which is much finer. Both have a good use. Certainly when you're getting inside an abdomen, particularly one that you're going back into, and it's perhaps a little scarred, this is ideal for finding your tissue planes, and it would hold, whereas this isn't robust enough, which is the Burkitt. Absolutely. But they both have good use. Certainly when you're inside a major abdomen and you're picking up vessels, something a little bit more robust, the Spencer Wells will be fine. But imagine that you're doing the blood supply, you're working up close by the bowel. A finer Burkitt is perfect for that, and it's not weighty, it's not going to pull and drag down the bowel and perhaps tear some of the little vessels. And now we're on to our fabulous little tissue forceps.
Some special shapes.
Lots of lovely shapes here for you. And again, if you remember, we talked about the forceps, some being traumatic and non-traumatic. It's the same when it comes to your tissue forceps. They're the real bread and butter of all surgery that goes on globally. Lane's tissue forceps, what would it be used for? Fabulous for going into an abdomen, again, that we're having to go back into, that's had particularly midline, and you're trying to find your tissue planes. You can grasp that, and it really will hold.
And you grasp hold of the fascial edge of the wound, wouldn't you?
You would, absolutely, because if you look, there's some pretty nasty teeth there.
Yeah.
You wouldn't want to go and grasp the bowel with that.
No,
You would undoubtedly tear a hole.
Yeah.
So that's for getting inside. You wouldn't use that inside the abdominal cavity. Great when you want to raise the stoma. You want to grasp the skin, hold that up when you march your stoma. Again, it will hold. Very reliable instrument.
Yeah.
Whilst we're on to the toothed instruments, we talked about tooth and non-tooth. We'll go on to the next instrument. Again, an Alice tissue forceps. Fabulous little instrument. For example, you're doing a paraumbilical hernia, you want something, you want to create your tissue plane, you're going underneath. It will use, and the same when you're doing breast work as well. And they're very strong, But again, you wouldn't use them on the side, but fabulous instrument. Now we're moving on to our non-traumatic Babcock. Again, a tissue forceps. Can be used inside axillas, can be used inside the breast. And can absolutely fabulous for the appendix, certainly when you grasp the appendix and you're working in the mesoappendix. If I can demonstrate to you, what I'd like to do is to show you. That's not, it's a little uncomfortable, not desperate, but I'm telling you now, there is no way I would put that would tear a hole in my thumb. So a great instrument for that, and again, it can hold the bowel and it wouldn't traumatise the bowel. Okay, that's our tissue forceps. Needle holders, great. Needle holders, you'll see lots of ranges of sizes of needle holders, but obviously this is an abdominal tray, and it ranges, as I say, the tray can be used from a hernia orifice right down to a major bowel resection. And if you look, there's all different sizes. And again, it's the depth that you're working at, but also a little clue, if you see a lovely gold-handled one, like I'm demonstrating here, yes, it's lovely and shiny, but it tells me there's probably a good tungsten carbide bite to it, which will hold the needle better, but probably with a good tungsten carbide grip, which will take the needle on some.
And then it won't twist.
And it won't twist. If you look, that's pretty good, and that's pretty much as I say. And it's these little giveaways that you open the jaws, you'll see the beautiful diamond shaping, and the nice gold handle. Many of it gets worn away, but you can tell it's a good quality needle holder.
Just whilst we're on that point, how do you like to mount the needle?
Generally, I like to mount the needle about a third way along the needle. I hope you can see that. And you would take, it would be in its packet, and it's designed that, and I can show you one later on, you would just advance your needle holder to about a third. Don't advance it too far along, and I'll demonstrate why. I've got a swab here. If you look, I can't really drive that needle. In America, they actually call these needle drivers. You can't drive the needle. So if you take the needle holder a third way along the needle, just advance beyond the tip, And if you look at the difference, you've got much more control. And incidentally, once the needle is finished, and I would always hand this to my surgeon, no shafts should never be passed other than in a kidney dish. Blades, needles of any description, infiltration, and I would expect the surgeon to hand that back to me, disarm it by just twisting that down. I hope you can see that. I'll do it one more time for you. Just twist the needle down. It's disarmed, but I still would expect it to be handed back to me in a needle holder in a kidney dish. Sometimes a surgeon will like you just to perhaps put an angle because he's got a difficult area to get to, but that is requested by your surgeon. Okay? But be aware that it's not always standard third way along.
Okay.
You've got Langenbecks here, small Langenbecks, and you've got medium Langenbecks. Common sense has to prevail. It's the depth that you're working at and how fine the tissue is that you're lifting to create a good view for your surgeon. So again, you look at the different sizes. Small, medium, and they would be used in all sort of small work and even major work just to get inside. We talked about raising the stone. We did, just, you know, trying to create a good view for the surgeon, and you're working alongside them, and certainly as an assistant, that's what we'd be doing. And a Morris retractor, I always think Morris around the maple, that's how I teach my junior staff. But a great instrument for lifting up, particularly. You can be up in the splenic area, you get a good view, lots of light can flood in. It's only a small retractor.
Lifting up the abdominal
absolutely, and it enables a lot more light to come in than perhaps sometimes using the larger retractors. It sort of caves in, if you like, and you lose the light. So, and it's a fairly comfortable instrument to hold. All of these are fairly comfortable. Okay. And that's holding an instrument, but then we come to self-retaining instruments, and that's a Travers self-retainer. And it's like the handbrake of your car. What we wouldn't want you to do is like that. Can you hear that? I hope you've picked that up. It's really like pressing the button of your handbrake that you would open up. And we've got different sizes and different depths. So I hope you can see that. So let's demonstrate that. Pressing the button there, and then you can spread the tissue. And we've got different sizes and shapes that go deeper down. Norfolk and Norwich, and then, yes, and other self-retainers. But it basically starts certainly on the general side with the Travers. Okay. I've got some towel clips here. Again, they're used to anchor, certainly after you prep your patient, that you would perhaps hold your diathermy lead in position for suction diathermy. Perhaps the scrub practitioner will hold her ties nearby or his ties so that they can just dangle down, pull the tie and offer them to the surgeon. Okay. Here we have a pulse sucker and guard. If you can see it opens. Probably used on major laparotomies and obviously major abdominal work. Certainly if you want to wash out. It doesn't clog all these little perforated holes. It basically stops clogging up, whereas a yanker will
the yanker is the long plastic.
Yes, it's the long plastic one. Again, all have their place, but this is a non-disposable instrument, whereas the yanker is a disposable instrument.
And it sucks all the way along the...
It does, that's right. So if you're doing, for example, a bubble test at the end of an anterior bowel resection, perhaps you can just pop that in just there, and it wouldn't block up the fat and mess. It's just so you're not going to obstruct it.
Yeah. Very, very non-traumatic, isn't it?
But again, I just want to demonstrate, and if you may see some places that you work, whereas the surgeons will take the guard, which I'm demonstrating to my left hand, and they will use that like a yanker, and often can use that. If you look at the tip, it's very atraumatic, and many will use that. It is a very good dissecting instrument, and again, not uncommon to see that being used. These are the diathermy forceps, which we'll be demonstrating about diathermies later. But also here is a very nasty needle, but many of our surgeons still want it on their set. Where would we use it? Again,
Pylonodal sinus.
Pylonodal sinus, absolutely perfect for that. And again, if you had to go to open on a laparoscopic cholecystectomy and you're doing a coccus incision, so to cut through the muscle, it's perfect. The next set I'm going to show you is the laparotomy set, and some hospitals call it the deep set. And again, it's just looking at very similar instruments that I demonstrated on the Major General, but what we do is we just go longer. So shall we start here? Bard Parker, I don't think I demonstrated that earlier, it's just that a little bit longer. The scissors, are a Nelson scissors, and I always teach people by saying think of Nelson's column, they're nice and long, and again, a great dissecting scissors. You can get even longer scissors when you're working very deep, doing certain low anterior bowel work, and again, even upper GI. So that's the Nelson scissors. We looked at non-tooth forceps because we talked about not using teeth inside the abdomen. Again, slightly longer pair there. And again, they just go longer and longer. As the deeper you go, the longer the instrument. We looked at the clamps on the previous set. That was the Burkitt's, the Spencers. And here now we have a Roberts clamp. Again, very, very good, nice and long, and they do have a fine tip. Now, we talked about the depth. What I'd like to show you at this stage, using a clamp like this, clearly if you're really down deep, certainly on left-sided bowel work, the surgeon's hands can't always reach down to do the tie comfortably. So what we would use then, and I have prepared one here, is a Leahy. So what you'd have then is this, imagine there's a vessel on the end there, the surgeon will just loop that round and run his finger down. And also again, if you're looking, certainly if you're doing upper GI work, certainly working around the cystic duct and the artery, they're ideal for moving around. We next move on our set, we have a Lord Moynihan forceps. Again, a good instrument just for tunnelling under. We did an nephrectomy on Monday and the surgeon was just very happy using his Moynihan to tunnel under, and also used in gallbladder surgery. Okay. We looked at atraumatic tissue holders. These are Babcock, again just a longer pair. And we looked at needle holders on the other set, and again we just got longer needle holders. Absolutely. Again, working very deep in those long dark holes. We now move on to the Rampy sponge holder. Again, we just have an extra backup on our set to load up some sponge on sticks, or again just to grab the gallbladder if we're doing up the GI. We talked on the previous set about retractors, handheld retractors, and we talked about comfort. We're now moving on to the Divas. As you can see, you've got different widths of the blade depending on where you're retracting, and they are designed ergometrically for the assistant so that it's nice and comfortable. But just remember that you may need a swab, particularly if you have to, on a very sort of delicate part of the tissue, you may need, absolutely, it could tear a hole and you've got to be very careful, so perhaps a swab underneath is a good idea. When we sit back of the trolley, now we talked about anything with teeth inside the abdomen, but I've left these on to demonstrate. Can cause trauma, but perfect. The only time that would ever go into the abdominal cavity, certainly on the general side, would be, you see these little things, these are called Leahys or Pledgets, depending on what hospital you have, and they're ideal just to grasp the Pledget forceps, and again used for blunt dissection. And
what are these ones called?
They're called cockers. Last and not least are our bowel clamps. In my right hand I have soft bowel clamps, and in my left I have crushing bowel clamps. To my right, I'm going to take them off the pin now and I'll show you quickly that what we've got here are doins, straight doins and curved doins, ideal just to go, they're soft, they're atraumatic, and ideal for all colorectal surgery. And we have a Stevens crushing clamp, but they are very traumatic and they will kill the blood supply to the bowel, so be very careful when handing over and what you ask for, that it's a crushing clamp and a soft bowel clamp. Okay, and that's pretty well it what we've got on our deep set here. So just think, the deeper you go, the longer the instruments, and just because they're not on the set, we have them as supplementaries, and we have much longer scissors, much longer forceps, and a diathermy forceps that we'll be demonstrating later on can go to quite considerable length, and we have them up to sort of this distance.
So moving on now, so this is the breast set, isn't it?
This is the breast set for our oncoplastic surgeon, adapted specifically for her use. A lot of the instruments are the same that I demonstrated earlier, for example, the forceps, the gillies, and the scissors. We talked about McKindo scissors, but if you look here, the scissors here, they're Metzenbaum, and they're tungsten carbide. They're very, very super DuraCut scissors, very, very good quality, and ideal for working on the breastwork, and certainly block dissections and axillas. You look at the skin hooks, very fine skin hooks to pick the skin edges up. We look at very delicate diathermy forceps here. And we have very specific, very fine nose needle holders because the needles are much smaller and more delicate to drive. So everything's that bit finer. But just to remind you that we still come back to things like the traumatic tissue forceps, because they're ideal certainly on a mastectomy when the surgeon needs to raise a flap, that the assistant can hold the flap up using those lovely, strong, robust tissue forceps.
To hold on to your axillary contents, bringing that down.
And axillary contents, absolutely, yes. And we showed you a pledget earlier, and we talked about blunt dissection. Again, we have a straight Spencer Wells, and the reason for that is just so it can hold the pledget, and again, using blunt dissection in the axilla. We talked about the Langbecks and the Morris. A Zerny, if you look, that's got quite, but again, if you're raising a flap on a mastectomy, really, if you look, it really lifts up and gives the surgeon that really important view, absolutely, without the trauma. This is a major orthopaedic tray. Again, we come along for doing major hips and knees. You've got sort of bare essentials on here. Obviously, when you go into orthopaedics, you're going to be going into major Meccano mode. But you still need your bread and butter instruments to get you through the procedure. A lot of it's very similar to what I demonstrated earlier on the Major General and the laparotomy set. The bar parkers, slight difference. If you look, this bar parker handle will take a much bigger blade because obviously you're doing, they want to do bigger incisions perhaps, and certainly cutting larger pieces of tissue away.
A little less delicate.
A little less delicate. You're not, yeah, absolutely. We looked at the forceps. These are Ramsay's forceps. If you look, they're not delicate. They're toothed and non-toothed, but they're really quite strong to get hold of that tissue. We've still got our little Makindo and our Gillies, those really important forceps that we talked about. We looked at the scissors that we had earlier. We've got the Makindo, the straight Mayos and curved Mayos. The clamps, you've still got vessels that may need to be tied. And in my right hand we've got the Dunhills, and to my left we've got straight and curved Spencer Wells. And that's purely, again, just a hold tissue, but sometimes to pick up a vessel as well that may need tying. In the next pin I'm going to be showing again Rampy sponge holders, Lane's tissue forceps, because again, not like inside an abdominal cavity, you can pick up quite a lot of tissue in there using those forceps. Those are all important needle holders. And then we move swiftly and quickly on to the very specific orthopaedics now. This is when it starts getting quite strong. Northfield bone nibblers, nibbling away that little bit of bone all around the hip, osteophytes, certainly on bunion work, a good instrument, a bread and butter instrument for orthopaedic surgeons. Baby bone cutters, just again nibbling that bit of bone cutting away. Retractors, you've got the Langbecks that you saw earlier on both sets. You've got a McDonald. Again, you would have that perhaps when you're making up the cement and the surgeon needs to take away the excess cement after they put the prosthesis in. And if you look, it's ideal. It just cleans away the cement so it doesn't stick to anything else. Here is a good old bone hook when you want to just, as I say, nasty, literally very sharp, but it is literally a bone hook and they will pull down on that. That's right, absolutely. Yeah. Traphown, or known as ring handle spikes, again when you're doing underneath a hip or even a bunion, a very versatile instrument, bread and butter for orthopaedics. Galabin's suture holder. In the general side of things, we tend to handle suture material, but in orthopaedics, infection can be very serious and very serious in bone, often for life, so you have to be very careful. All procedures are performed in laminar flow theatres. We don't handle the swabs with gloved hands. They're handled with these forceps or the Galabins when they're sewing up the end of the suture, and the assistant can pick up the suture, but not with a gloved hand. So a versatile instrument there. All of the things I'm about to show you now, to my right is a Robert Jones and a Bristow's, and they'll just be used to clean away any sort of connective tissue off the bone. Can be used again like a ring-handled spike if you look, just to elevate any parts of the bone. Curette is not uncommon just to have to curette around little bits of bone and things. An instrument that's used on, you can get a smaller one when you do a ingrown toenail. We do that in general surgery as well as orthopaedics. You'll find that. And can be used in a multitude of surgery, cleaning out. We talked about abscesses and things.
Lines.
Yeah, that's what you'd use it for.
Is it the same as a Volkmann spoon?
Volkmann spoon, absolutely. And again, in orthopaedics, they range in size. they could go up to literally a great big sort of tablespoon size, certainly when you're cleaning up femoral canals and things. Self-explanatory, the mallet. You know, you walk past any of our theatres, you know, near and orthopaedic theatres, the banging that you'll hear. Very heavy, and often placed down by the surgeon on the patient's chest, which is, you can imagine, it weighs, if you have a feel mat, that's quite weighty. So be very careful where you place that mallet if it's handed to you. It shouldn't be left on patients' chests and on legs and things. We talked about self-retaining retractors, we talked about Travers, which you saw earlier on the general set, and we talked about Norfolk and Norwich, and incidentally there's one here. If you look, it's much deeper. Okay.
So that hip wound or
hip wound, and sometimes we have to use them on very obese patients that perhaps are having a very deep hernia or a smaller sort of midline type operation. But it's a good orthopaedic instrument, and they would use perhaps a couple of those to keep a good field. And that's pretty well bread and butter stuff, but remember there's a lot of very specific trays that always come through on orthopaedics, and they have all the other, all singing, all dancing instrumentation for you.
So what have we got here, sister?
Well, this is a basic SMR, submucous resection tray for nose surgery. I'm not an ENT sister, I'm a general sister. However, I have been in theatre for a number of years, and I can hope to endeavour to take you through what we've got here. The classic forceps that we said are very common. Here we are again, the Makindo, the Gillies, a great instrument. All surgeons love them. A dental syringe, again, can be often used in general surgery, but you would have a disposable glass ampule with your lidocaine, with adrenaline or whatever, and you'd have a dental needle on there. Obviously, we've all seen these in dental surgeries, but that's what they use in the nose. Then you've got to keep your nasal passages open to do the surgery, and you've got oops, sorry, killing there. So you just open up. These are little nasal retractors. Can I demonstrate? Yep. So you just would hold open the nasal passage and comes up. Okay.
And what's that called?
That is a Killian nasal retractor, and if you look, they go up in size, which I've laid here, because everyone's nostrils are different sizes, and then of course the further you go up in the nostril, the deeper you go and the more access you need, so you need to have that nostril kept open. Then you've got the blade, because the surgeon will need to cut around to go up the submucous membrane, and it's a much finer BP. You'll hear BP. BP stands for Bar Parker. I've referred to it several times today. Then you have like a dissector that lifts the tissue, the submucous membrane, going up there. Howarth, again lifting up. And then when you get to the cartilage, you've got a Tilly Hankel. And incidentally, if you look, we've got gallipots. That will be filled with water, because as they bring the cartilage out, obviously there's something kept in the jaws. Now we're not just being very silly about the surgeon just washing out the tissue in the gallipot. In this particular surgery, certainly doing SMR, if it floats, you could have part of the brain. So you've got to be very careful. So that's why we do it. Apart from cleaning what we call the nose of the instrument, you want to ensure that it's just cartilage and not bits of the brain. You haven't gone too high up into the nose or into the brain. These are nasal scissors, and these are all different bits of polyp forceps type thing, just to get some more tissue out. And if you need a little rhinoplasty, as if you look, you've got me in the frame, I probably do need it, you'll get a little instrument there that will just rasp a little bit of bone away from the top of your nose. And again, we looked at the bone cutters that we had earlier on the orthopaedic set, but these are specifically designed for nasal work. If you look, they are designed to close, to go up the nose, and you can nibble bits of bone away. Okay. We looked at the hammer earlier. If you look here, there's a beautiful little toffee hammer, and again, the surgeon could be chiselling, and you just do gentle tapping, and they will direct you, and they will just say tap tap. Needle holder, that beautiful gold handle which tells me that it's a beautiful tungsten carbide grip there, which it is. Much finer to take that small needle. Dressing forceps, just to pack the nose after. And again, these are just little nasal retractors. Fine retractors, we looked at suction earlier, we looked at great big suction, but you can see this little delicate nasal sucker here, and that incidentally is a stellette, which pushes away, if it picks up bits of bone, you just advance that through here, and it will just clean the end of it, so they'll always have a stellette. Okay, and again, diathermy forceps. And that's just a very quick overview, but it gives you an idea that basically you've all got little finer retractors, but you'll recognise lots of little instruments that you'll see on every set throughout every theatre. Okay, whilst talking to you, showing you the sets, we talked about diathermy forceps and diathermy leads that you saw on the previous sets. But let's talk about electrosurgery, otherwise known as diathermy, commonly known as diathermy. There are two distinct types of diathermy that we use here, and that's monopolar and bipolar. Monopolar is the most commonly used type of electrosurgery, and the AC current is delivered to the forceps and through a lead that is attached to this machine, and the patient has a diathermy plate that is attached to their nearest site of surgery. So if you're doing a left-sided hernia repair, you put it near the left-sided part of the body, because the current doesn't have to transfer quite so far around the body. Can be used handheld or using a foot pedal, which if you look down you'll see there's a range of foot pedals here. Here is the monopolar for coagulation, the yellow is for cutting, and you can use this on blend, which will cut and diathermise at the same time, and the smaller pedal is your bipolar, which we'll talk about in a minute. Monopolar, as I said earlier, is the most common type of diathermy used here, because you can use it on a range of different tissue types. So you have to ensure for safety that you've got your plate, and I'm demonstrating, we on this site have a split plate, and the reason behind that, once the current has gone through the forceps that leaves here, the lead to the forceps, it goes to the tissue, and then the current comes back via the plate to the machine. If for any reason the plate becomes loose off the patient's leg, not always the leg, sometimes it's popped onto the abdomen, you've got at least one side that can keep contact, because otherwise the current, for example, if the patient's laying with their hand beside them and the current can come out to a wedding ring or any ring, and the patient can get diathermy burns. Very, very serious. As we all know, burns take an awfully long time to heal, and it is deemed very, very serious. Bipolar surgery. Now, bipolar surgery is used very differently. It's where there's just a different, there's not the continuity. You've just got the lead that goes into the machine here, goes through, and the forceps are closed, or scissors, because we use bipolar scissors also. You haven't got quite so much flexibility. But again, it's worth knowing, for example, if you've got patients that have got pacemakers in, that maybe you could use the bipolar. But as I say, the preferred choice is the monopolar. Just a brief overview about diathermy safety. If your patients have come to theatre, we should check that they haven't put lots of body lotion on, that you've got a good skin contact with your diathermy plate. Ideally, the plate should be split. Diathermy forceps should be checked. They're often well used, and you can get cracks in them, so the current could come out and could actually burn you as surgeons. So always examine that and the lead. You will find with the machines now, they're very